Good afternoon, everybody. Thank you for having me here today. My name is Gabriela Ortiz. I am a respiratory therapist in the San Diego area. I am here to talk a little bit about trachs and talk about invasive ventilation because I'm sure that is a question that is in everybody's mind right now. I just want to introduce myself. I've been a respiratory therapist for a little over 12 years. I've worked in the hospital. Most of my time has been in home care. So everything I said in school that I wasn't going to do is what I'm doing, and I loved it. So home care has been pretty much one of the most rewarding positions that I've had in my career, being able to help those people who are just in a world of devastation and a world of so many questions and not knowing what to do. So helping you is rewarding to me. So you can see I've been in sleep therapy, I've been in sales, but I am a huge ALS advocate. I've been working with ALS Association for about 10 years now. So I'm very familiar with the different types of ALS, with the progression of ALS, with what comes first and what progresses along the way. So please, if you have any questions during my presentation, please feel free to ask. I'm open to questions, anything that comes to mind, and let's get this going. So today I'm going to talk about invasive ventilation. Maybe some of you have already seen or has had the conversation of non-invasive ventilation. So non-invasive ventilation can happen with a mask to your face, either to your nose or to your nose and your mouth. So pretty much that would be considered non-invasive ventilation. There's also a different modality that's called mouthpiece ventilation, where you use a little mouthpiece to your mouth, either holding it yourself or with a device attached to a wheelchair or attached to something, so you can just scoot your neck over and just be able to reach the mouthpiece and take a breath. Right now, the two devices that are being seen the most out in the field, or from my experience that I've seen the most, are the Trilogy and the Astral. They're made by two different manufacturers, have been working very well for non-invasive ventilation, and if we need to progress into invasive ventilation, the same machine can stay in place. Okay? So those of you who have already seen it, I'll be repeating myself a little bit. Okay? The machine here, the Trilogy, can accommodate different settings, different modalities, just customizing to your compliance, to your breathing pattern, to any type of progression in breathing that may happen. The Astral here does exactly the same thing. The Astral is one of the newer machines, has only been out in the field for about 3 years. Also can accommodate non-invasive ventilation, mouthpiece ventilation, and move into invasive ventilation. Okay? I have a picture up there of both of the devices, if you can see that. I have a brochure here that we could possibly share with you at probably a later time. I'm not sure if you can see this very well. It just shows the setup for ventilation on a wheelchair. So just because you are now on a ventilator does not mean that you are tied to the bed. You can still move around, you can still travel, you can still go shopping, you can still go to the beach. So I will leave, anybody needs one, I will mail them out to you, or they can be picked up at my office. So I have this for you. Let's move on. I want to talk about after non-invasive ventilation. Ventilation can prolong life, whether it's invasive or non-invasive. So if we start to get into a period of shortness of breath, or using your shoulders to be able to take a breath, sometimes you may not realize that you're struggling to breathe, but that's a sign that maybe ventilation is time to start. Invasive mechanical ventilation, I have the definition up here, is a life-saving, life-assisting intervention for individuals with respiratory failure. In the event that maybe you don't feel like you're in respiratory failure, go back and think about, how are you actually breathing? Are you actually able to take a deep breath? Are you actually feeling energized when you breathe? Remember this, we need to breathe in oxygen, but we also need to exhale CO2. When we start retaining CO2, that's when you're going to start to notice that you may be tired, you may feel lethargic, you may feel non-focused, you may feel that you're just not yourself and you need to get energized. A lot of the times, we just need to do what's called wash out some of that CO2. We can wash out CO2 with the different types of machines, either the Astral or the Trilogy. There are other machines out there as well. I just haven't seen them as often as I see these two here, okay? So keep that in mind. Yes, I have a question.
So some folks constantly monitor their oxygen level. How do they know their CO2?
CO2 is not as easy to monitor because you cannot check it with a little finger probe, the little pulse oximeter. The CO2, pretty much as I mentioned before, you'll start to have signs and symptoms. You'll start to feel lethargic. You'll start to feel like you're sleepy all the time. You'll start to feel irritable, non-focused, anxious. So those are signs and symptoms of increased CO2. So at that point, we need to call the doctor, we need to make an appointment, and we need to have that CO2 checked. It can be checked at home with the machine, but it's something that we need to look at because a lot of the times insurance will not cover that particular type of study. So it's something that we should go to the hospital, outpatient clinic, either or, and we can get that checked, either by a probe on the ear, on the forehead, or actual blood test. Okay? Thank you. So to move on, invasive ventilation happens through a trach. Invasive ventilation is now a step up from that mask through the nose or through the mouth. So now we're looking into a trach. So the trach is a surgical opening in the neck that leads into the trachea, which is the breathing tube, that's maintained open with a hollow plastic tube called a tracheostomy tube. For short, we call them a trach. There's different types of trachs, as you can see in my picture up there. Trachs that are just straight, trachs that have a little balloon, trachs are longer, trachs are shorter. So when is the time to choose a trach? Here's a picture of where the trach is inserted during surgery. But when is the time to think about a trach? The time to think about a trach is, what do we want to see in 1 month, in 2 months, in 3 months, or in a year? Okay? Our disease progresses. Progression is never known how quick it progresses. So we either sit down and we decide as a family, as a group, whoever your support is, when do we get a trach or do we get a trach? Okay? Do we get a trach emergency situation? Maybe you didn't want that. So sit down and think about it. What do we want to see? Yes.
So for our audience,
Yes.
why is this an important decision?
Important decision because there's a lot of care that happens with the trach. We have to do trach care. We have now different infections that could happen. We have a trach that needs to be changed out that requires specialty personnel to be able to change that. It requires that we need to learn about life support. We need to learn about what we do in case the trach pops out. There's just different little details, but it's not something that we should be afraid of either, okay? The trach is not a bad thing. It's something that should absolutely be thought of. Do we want to see that graduation? Do we want to see that wedding coming up? Is there a new baby coming into the family that we want to see? So this is a matter of when we decide, do we want to prolong life? The trach is there for that reason, okay? At this time, we also think about secretion management. If your muscles are weak, your muscles are getting weaker, You also have your diaphragm, that is your muscle to breathe. So your muscle to breathe will also get weak. So now you don't have that ability to take in that deep breath and be able to cough. So a lot of the times, if we can't cough up those secretions that are either stuck in our lungs or even just in our throat, a trach can assist with removing those secretions as well. Not necessarily meaning that we have to go on invasive ventilation just yet, but the trach can help with secretion management. If we manage our secretions, we can manage any type of infection as well that can go into the lungs. Okay? So trachs. The decision is made. A trach does not mean you cannot speak anymore when you get the trach. If the ability is there to still speak, a trach can allow you to speak still. You can add what's called a Passimir valve. Come in different colors depending on the consistency or how much initiative you need to pull in to get that breath out to speak. So white, purple, green, if you're on a ventilator, invasive ventilation, you can still speak. If you get a trach, it does not mean that you can no longer eat. You can still eat with the trach. It just a little bit slower, okay? So it's not something that we need to be absolutely afraid of. So these are things that we need to think about. Sit down and think about, what do I want next? What do I want to see later? Okay? Yes.
So if I don't make that decision and I enter into a respiratory emergency, my family calls 911, I go to the ER, what's going to happen?
Well, if you don't have an advance directive set in place, you get to the hospital, they're going to intubate you, and they're going to put you on invasive ventilation. Now, if you've already thought about it and you have decided not to be trached, you need to have that in writing. That way, when you do arrive, you are in an emergency situation, they know to put a mask on you. You will have a mask to keep you comfortable. At this time, they either clear whatever the emergency is non-invasively. If there's nothing in writing, they're going to take every measure to make sure that everything is taken care of for the reason that you came in. Okay? So one way or another, it's best to decide. Do I want it or do I not? Okay? Very important to have the support and to think about this prior. Okay? Because the trach does involve more care, as I said before. Okay? Yes, questions?
So I've got a trach at the emergency room, and they won't let me go home. What's that all about?
Well, when you do get a surgical, any type of surgery, especially in the neck with this trach device, it's going to take a few days before they can evaluate, is it safe for me to go home or not? So that surgery needs to be, they need to be sure that it's actually healing. So we can't just put a hole in there, stick a tube in it, and send you home. No, we need to be sure that it's healing. There needs to be some sort of, we don't want active blood when you get a surgical site, okay? So the trach will need to be changed in the hospital at least once or twice before going home. So it's the whole tube appliance, okay? You may have stitches on the side. Sometimes people go home with stitches. As a respiratory therapist, I like to receive a patient in the home with no stitches left. I like a stable trach now, because now I can change the trach in the home if I need to change the trach in the home, okay? So it's something that we just want to be sure for the safety to not, we don't want to cause another infection. We don't want you back in the hospital. So we do need to heal that trach, okay? Did that answer your question?
Somewhat. And can you just go on to the training 24/7? Who's handling this machine for me? Because
Yes.
if they're not in place, I also can't go home, right?
Absolutely, yes. So when the trach is in place, like I said earlier, you're not always on ventilation when you go home, okay? You might have been weaned off of a ventilator in the hospital prior to going home, but if that is not the case, they will have to call a company like myself to bring out a ventilator, whichever one the doctor decides he wants to use that best fits you. A lot of the times the doctor will leave it up to the company that's called a DME company, or a durable medical equipment company. He will let that therapist decide which ventilator would be best for that person. So what happens then is we come into the hospital, we introduce ourselves to you, we talk to you, we ask questions, we look at what type of ventilation you've had in the hospital, because we want to transition you home as comfortable as possible. So the machine does need to be set up at your bedside in the hospital prior to going home. Usually, from my experience, I like to have the ventilator there at least 48 hours before I say you're ready to go home. Why? Because I have to go to your home and evaluate to be sure that the home can tolerate machines plugged in different places. I can't have power strips all over the place, okay? I know that's the easy way, but these machines do need to be plugged in to wall sockets. They need to be secured, because this is now life support. So if the power goes out in the middle of the night, we need to be sure that we have power to keep running these machines, okay? I'll talk about the power in a little bit, but I'll go back to going home. So 48 hours, I do need to meet with the family, the caregivers. If there's any nursing agencies in place where we're gonna have nursing care at home, we need to train everyone who will be at the bedside to help take care of the person in need on these machines. How do they work? How to troubleshoot? What does the alarm mean? How to put together the tubing, as you can see here out of some of the machines. How often to change the tubing. Because remember, you're breathing in and out through these, so we need to be sure that nothing goes back into your lungs to cause an infection. So we need to be sure we are cleaning, throwing away anything that is not washable. Okay, so training needs to happen. As we go down the line, we need to be sure that everyone is comfortable with this. The day we do decide to go home, it is a day of anxiety, okay, because you have been dependent on hospital staff to take care of everything. Now we get home and it's overwhelming at times. So re-educating happens when we get home. Okay, we need to learn how to use an ambu bag. We need to learn how to do CPR, just in case that's the step that we're gonna go. So yes.
So what does the bag do?
The ambu bag is a bag that gives you air as the person attach it to your trach. If there is no trach, then there's a face mask. Person needs to give air in a slow rhythm, not overbag.
So the power's out.
Power is
My
out.
battery backup just stopped. I use the bag.
You use the bag, yes. So at times, bag will be your best friend. Keep the bag at the bedside. Keep the bag hanging to the side of the bed. Always have it visual. So that's something that, as a respiratory therapist in the home care world, I emphasize on that. When I come in, I make periodic visits. So I just don't leave you after you get home. I kind of try to wean myself off because sometimes you want me to stay, but eventually I have to go home myself. So the first day or the first few days, we're together a lot, answering questions, talking about different things of how I can change, how is my trach going to be changed, how is my trach care going to be done, how often is it going to be done, do I need suction, do I need, there's just different things that are going to come up, okay? So I'm there the first day, I come by the next day, I may not come by for a week, and then after that I won't see you for a month. So this is something that you are responsible for the whole care in the home, whether it's family, yourself, or nursing, okay? If I choose invasive ventilation, as we discussed, family caregiver support is crucial. Remember, there's going to be equipment in the house. Your bedroom is no longer going to look the same. If blue does not match the decor, then we have another option. So just remember, there are options to everything. A lot of times we're not worried about the decor, but we're worried about a machine that's going to make us comfortable. So that is something that we can decide, like I said. Both machines, other machines can be customized to how you breathe for your disease progression. Okay? We need to learn how to use the equipment we talked about. Also, financial support is crucial. A lot of the times, insurance may not cover the equipment 100%. So we need to be sure that we know financially where we stand with this type of equipment. Okay? So let's go back and let's talk about the power. Both machines have the ability to have an external battery, but also have an internal battery. Both of them are able to accommodate more than 6 hours of power in the home if the power goes out. The Astral can accommodate more, 12 or more hours. Okay? We can always add external batteries. We can always supply with more external batteries. If you decide you want to go on a trip, just let your DME company know so they can accommodate you with more power. So invasive ventilation does not always mean you're going to be tied to the bed. Okay? Questions? So far? No. Okay. Let's go back and let's talk about that trach. Okay. The different types of trachs that are placed in the hospital may not always be the trach you go home with. In the hospital, you will definitely get a trach that has this balloon. I'm not sure if you can see this very well, but there's a little balloon that hangs on the outside. So when you're wearing this trach, there's also a balloon that's going to go inside. What that does is it keeps the air from staying in the lungs and not escaping from outside of the surgical site, okay, or escaping out of the mouth or the nose. In the hospital, it's very important to be sure that whatever air we put in you, we want to see that the air is also coming out, okay? In the home, things change, okay? In the home, it's about comfort. In the home, we still want to know what's going in, but we also want to know what's going out. And we're able to monitor that with both of the machines, either invasive or non-invasive. But in the home, you're going to see a trach more like this without a balloon, if you're able to tolerate it, okay? If you have a trach without a balloon, air will escape. You will feel air escape from the side. That's called, the surgical side is called a stoma. Air will escape from the stoma. You may feel air escape from your mouth and from your nose. As a respiratory therapist, we always like to get cushion settings from a physician just to accommodate for that extra leak, to be sure we're getting enough air to you, okay? Your lungs need a certain amount of air. Everyone is different, depending on our size, depending on our height. So everyone is different on the amount of air that we need to get, okay? Invasive ventilation needs to be applied to the trach. If you look on the different websites and you look at the different modalities of applying it, it can be applied to a tiny baby. We have babies at home with a trach and on a ventilator. Helps them grow. They either stay on the ventilator for the rest of their life, or eventually some of them will be able to wean off of the ventilator. Maybe the trach stays in a little bit longer. But remember, the trach sometimes is there for secretion management, not always for invasive ventilation, okay? So the babies, they thrive. They thrive on this type of modality. Adults, gives us life back. Think about this. If you're on non-invasive ventilation right now, you're either wearing a mask on your nose or you're wearing it over your nose and mouth. Exactly. You're using it while you sleep, but eventually, remember, our diaphragm is our muscle to breathe. Our muscles are getting weaker. We're going to start to wear this mask more and more hours, not just for sleeping. I do have many people that I visit now that are wearing their mask 24 hours a day, okay? So this mask is now crucial to have on them day and night. If you decide on the trach, now people can see your face. Okay? So now you're just applied with the trach here, and now the machine is attached to the neck. Okay? So think about that. Face, or you want people to see your lovely face every day. So that's always nice. Okay? So trach is not always a bad thing. Okay. Now yes, question.
I'll let you finish, and then we're going to circle back
Okay?
to initial diagnosis
Yes.
and then the flow. When's it appropriate to have these conversations?
Yes.
And so forth.
Okay, so initially I want to start from we're going to go all the way back. When we're first diagnosed with ALS, it's a time of, what do I do? We're either in denial, or we're lost, or we have all this anxiety about what is going to happen. Okay, so we need to really take advantage of any support groups provided by your healthcare team, by the ALS Association, by any respiratory therapist from a DME company that's willing to sit down and give a plan. You know, we always think about our plan financially. You know, we have 5-year plans, 10-year plans, long-term plans. Well, now this is the plan for my life. You know, this is not solely what am I going to do financially to build a house or whatever it may be. This is the plan of how am I going to live my life? How am I going to live my life with my family? I want to live it to the fullest, okay? So we need to think about that. So after we get diagnosed, it's all about getting information. Get as much information as you possibly can. Like I said, your caregivers, your ALS Association, YouTube videos, there's YouTube everywhere talking about the different types of ALS. So progression happens differently with everyone, okay? I have sat at the ALS clinics, and we talk about prevention. So it's all about knowing how can I prevent from ending up in the hospital, because a lot of the times we end up in the hospital, we're going to catch something else, okay? And we're going to end up in the hospital and stay there longer than we needed to. So it's a matter of prevention, prevention, prevention. Short of breath. First signs and symptoms. Look into non-invasive inhalation. Be sure that you look into that. Next would be, are we going to do nasal or are we going to do full face? Okay? Let's talk about that trach. Are we going to decide to take that step? Do I want to see that wedding, that graduation? I had a woman that I took care of, and I'm just going to say her name's Gracie. She decided to get a trach because she wanted to see her youngest son get married. Well, she was able to see 3 weddings from this gentleman. So the trach helped her to see what she wanted to see. She only wanted to see 1 wedding, but he did end up getting married 3 times within her life. So this is something to really think about. It's not something to be afraid of. I know I had another gentleman where he was afraid of scaring people. He didn't want to look scary. There's ways of covering it. There's ways of making you look as normal as possible, because that's what we want. But in reality, just think about this. People just want to see us for who we are. So it's not a matter of, oh, they're going to get scared. Let's not think about that. Let's think about, what do I want to see? Who do I want to see? I had a gentleman who was a teacher. He decided to get a trach, and he was able to get set up on the wheelchair setup that I showed earlier. And he was able to go to the school because they had a rockathon for him to save money to donate later to ALS. And he was able to go to the high school, trached on event. Nobody looked at him as being scary. They looked at him, oh my gosh, here comes our hero, our teacher that we just absolutely love. So it's a matter of just deciding where we want to be. What do we want to do? What do we want to see? Okay? Did that answer that question? Okay. As we go through the progression, it's very important to keep up with your appointments, to keep up with support group if there's any questions. I know a lot of the times when we say, oh, well, I don't get anything out of it. Ask the questions. No question is a question that will not be answered. If I don't know, I will find out for you. Okay? And I'm sure ALS Association deals with this every single day. They will have the answer for you as well. Yes.
So I've decided I want a trach.
Okay.
When do I pull the trigger? Is it time for me to go get the procedure done? How do I know I need to do it?
How do you know?
Without going all the way to emergency.
Yeah. And that's something that we need to sit down and we need to talk about. Go to your physician. Think about this. Am I at a point where I have done anything and everything non-invasively, either through my mouth or through my nose, to be able to clear secretions or be able to breathe? Okay? If you are now having to wear your mask more than just for sleeping, and now you want to leave it on a little bit longer, now is the time to think about it. Okay? Let's not think about it when we aspirate. If we don't know what aspiration means, it means that you're suddenly eating and you start choking, and that piece of food now goes into your lungs and it does not go into your stomach. So now that is called aspiration. That goes into your lung. With time, and with a very short time, it becomes pneumonia. That's when it becomes an emergency situation. Those of you who already know the cough assist, and it's a machine that it helps with, it initiates a fake cough, basically what it does. If that machine can no longer help the food get out, now is the time to think about that trach, okay? Think about the trach before you have to get it. Before you, and have to, I mean by emergency situation. Because then a lot of the times, you know, if you didn't leave it in writing or you didn't decide, then they're going to trach you either way, and you're going to wake up like, what the heck is going on? Okay? So decide. I think I just clicked something wrong. It's best if you decide, you on your own, when you want to get that trach. Okay?
So in my regular visits to clinic,
Yes.
and the respiratory exams, there's no magic number. You know, I've dropped from 33 to 17%. Now's the time. It's pretty much an individual.
I would say personally, it's an individual decision. You know, sometimes when we're in denial, we think we don't need it. We think we're fine. People see you. People see you day in and day out, and they're telling you, hey, maybe we should start talking about it. You're going to say, no, I'm fine. Okay? Everyone's disease progress is different. Everyone's needs are different. But think about it early. Early is best to think about it. Have that plan in place. Okay? Because it's going to be easier on everyone, especially you. You know, you're the only one who knows how you feel. Okay? We can only see it and we can only guesstimate, but we don't know exactly how you feel. Think about it before. Okay? Always, you know, maybe not the day that initial diagnosis happened, you know, that's just overwhelming, but it's something to put in that plan. Okay? Okay. Well, we still have a little bit of time. If we have any more questions, please feel free to send those questions in. Like I said, I'm a respiratory therapist. I am also a therapist who does the setups myself. So I do work with you personally as well. We do have a team of therapists, and pretty much we are very, very experienced in ventilation. So it's a matter of, we will never give you too much air, as I have a gentleman telling me that, oh, I just like to come there to give him too much air. No, we like to give you the amount of air that your lungs need to keep you oxygenated and to be able to get that CO2 out. So that's called ventilation. So we need to be sure we're ventilating you correctly. If we have questions, I'm a phone call away.
So people get a bi-level or BiPAP,
Yes.
and very quickly non-compliance. Maybe an hour or two a day, maybe not at all. What should they or their family do in that situation?
Well, non-compliance is going to be your number one issue. Why? Because again, we're fine. We don't need it. But a lot of the times it'll be maybe it's not set correctly. Maybe there's too much air. Maybe there's not enough air. So it's a matter of making sure that your respiratory therapist gets that machine to pinpoint to be able to get you comfortable. If for some reason you've already exhausted all of the settings that you could possibly do on a BiPAP, because it's more of a simpler machine than you have here with the Astral and the Trilogy. So maybe just the bi-level is not the machine for you. And a lot of the times progression happens quicker, so the BiPAP will not sustain anymore. So now we need to think about the Trilogy and the Astral. That is the much safer and easier way to go. But bi-level is usually always where we start. Okay, and if it's only using 1 or 2 hours a day, it's better than none, but it's better to sleep with it. You need to be able to rest. Your body needs to rest. It helps you gain endurance to be able to get up in the morning and do what you need to do next. So let's really look at that bi-level. If you have questions that maybe it's not working well for you, please call your DME company or your respiratory therapist to be able to get that what's called titrated, set to the numbers that you need, the pressures that you need, okay?
Are there options on mask versus nose piece versus a full face mask?
There's hundreds of options on these type of masks. My goal is to make you comfortable. I want you compliance with therapy. So I always say comfort equals compliance. If I get a mask on you that is not comfortable, I'll see if it's not comfortable because I'll see that the air is not going in. I'll be the first to say, okay, I made a mistake. That's not the right mask. There's hundreds of choices. ResMed, Philips, Fisher & Paykel. I can't think of all the brands, but there's hundreds of brands where there's a mask for everyone, okay? There's a mask that covers your whole face, as a matter of fact. You know, I had an actor who was diagnosed with ALS, and he didn't want marks on his face. Sometimes when you wear a nasal mask, you'll start to see that little groove or that little mark on your nose. If you wear a full face, you might see indentions on the side of the face. He was an actor. He didn't want marks on his face. So he wore a full face mask. So he actually had it accommodate his whole face. So there's so many different options. Nasal, cushions, pillows. I mean, all this is probably like, what? Look at the pictures on the computer. Look at the pictures that we have available to you. Call us. Well, we have samples that you can look at. We have samples that you can feel. There's different fabrics. There's a silicone. There's the new mask that has a very porous feel that doesn't make you all sweaty. So there's just so many different options. I do tease with some of you that have beards. When you wear a full face mask, sometimes you get a lot of air leaking. And I always say, don't worry. I have the razor in my bag. We can shave it off. It's not a big deal. And then they just look at me like, what? No, not going to happen. But there's just options. I'm here to make you comfortable. So that was an option, and he wasn't going to take it. But hundreds of masks. So please.
So when Brand X brings out my bi-level and 3 masks maybe and leaves, what do I do? I mean, you make them come back, right?
You make them come back. It's very crucial to be able to be fitted with the correct mask. So the mask fit should be snug and not tight. Sometimes not sometimes, all the time. I have all this air leaking. So you tighten the mask and you tighten the mask and you tighten the mask. That causes the indentions. A snug fit is what we want. So your respiratory therapist should be able to fit you with the correct mask and a comfortable one before they walk out your door. Okay? More questions? I'm not sure how we're doing on time. Okay?
So thank you very much.
Well, thank you very much,
Appreciate it.
Keith. Thank you for having me.
So again, you have Gabrielle's contact information. We'll put it on the YouTube notes in our other places we placed the video for you. Thanks for joining us for this care service meeting on respiratory and invasive
Ventilation.
ventilation.